take very small steps in understanding just the pathophysiology of these patients, because, you know, I'm always thinking that the manometry is going to guide me a bit better, and sometimes it doesn't. Sometimes it doesn't give me enough information to understand what is happening with the patient, and that's the honest truth. So I guess at this point, anything on the managerial side of things, I'm just still exploring, still playing with it. I haven't got enough data to be, you know, definitive about it.
Okay, thank you very much.
I ask the audience if somebody has questions for Dr. Athanasakos. Not anymore. Listen, Eleni, if you want, you can go with your case study.
Okay.
If you're
Thank you very
ready.
much.
Okay. Go ahead.
Okay, so this is a very short case study, which my colleagues and I chose the other day to see because obviously I'm quite biased. I think they're all interesting, but I wanted to present to you a patient that wasn't organic, so it wasn't Hirschsprung's or anorectal malformation, but a simple functional constipation patient. I'm just going to see if I can minimize this so I can read the. Yes, so this is a history of Mario. He's an 8-year-old boy, has long-standing constipation and fecal incontinence. Mum, when she came to see me, said he passed meconium within 24 hours. He was toilet trained when he was 2 with no issues. And she first noticed a change in his bowel motion when he was about 5 years old. And the main symptom he was having was fecal incontinence and sometimes hard stools. He's tried Movicol, suppositories, but he simply did not comply well with rectal medication as well. So he tried all the conservative measures. So when I met him, he was opening his bowels daily to every other day, type 4, and he was using Luxido and Senocot. So he was using a softener and a stimulant, which appeared to be working. So he occasionally he can have bad weeks where he won't pass a bowel motion for about 3 or 4 days. He sometimes has abdominal pain, which improves with the bowel motion. He rarely strains during defecation, he says, and he has no PR pain or bleeding. He sometimes feels incomplete evacuation. He usually goes to the toilet after school, and he sometimes withholds. He has daily episodes of passive fecal incontinence. He says he's not aware of this, and has fecal urgency sometimes as well. He also has bladder incontinence, which is usually when he's fecally impacted, which I'm sure we all know happens quite often. The school are not very understanding. I think in the UK, the schools don't really appreciate constipation to be a condition, so I just struggle to get them to support things. But they do sometimes allow him to go to the toilet most of the time, but they don't always notice when he has that accident. So he can be sitting in his poo, so to speak, for a very long time. He has a reasonably good diet and drinks about 3 liters of water and squash daily. But the most troublesome for Mario, when I asked him, what's the worst for you? He said the incontinence, and he gets very embarrassed and has been bullied at school from a very young age. He also has ADHD, so there's also an element there of sensory issues. So there's a behavior as well as a physical component. So looking at the bowel scores, like I mentioned before, they're all abnormal scores there. So his symptoms are very, very, not based on the history, but also on the scores. He's not doing at all well. What's interesting, or his sphincter complex is working in terms of function very well. And he says he has passive incontinence and sometimes fecal urgency. And you can see here that he does have an element, a very small amount of hypersensitivity. So he has that urge that's very quick for him. So this is his trace, which I'm going to go into detail. So as you can see, it took a while to stabilize him. Test his rest, squeeze, cough, endurance. He was able to hold on for quite a long time. He had a normal rare and rectal sensation as well. So this is an example of a patient who comes and sees me and says, I don't strain, I know how to push, and I sit on the toilet and everything's fine. And as you can see here, he's got an element of dyssynergia there. So he's putting all his effort into his anal sphincters with very little rectal propulsion there. And I find, so I don't traumatize them. If they're already here to see me, I might as well teach them how to push properly. And I show them the screen and I tell them this, and I do have cartoons and so on, but I show them this so they can see, look, you know, this is very red. You need to be squeezing much less and using your rectal and your anal pressure in coordination. Obviously, he hasn't succeeded in one day, but you can see that slowly he's learning how to do this. And I think that's really, really important. And I tell him to do exercises every day. His transit study, again, you know, it was normal. He had one, I think you can see one marker left out of 20. So based on his history and based on his transit study, you can see his typical constipation, but there's an element there that was very obvious looking at the physiology that he would benefit from some kind of biofeedback. So this is the way I'm presenting this case study is how I present my report once I'm done. So in this case, I said that HRM demonstrated normal resting and squeeze increments. He had a rare present. Sensation was borderline hypersensitive. Divulcation showed type 2 dyssynergia. I said that I spent some time with him to know how he should push correctly. And what I find very interesting is that the kids find this very useful because they're not aware, no one's aware if they're pushing correctly or not. I discuss all the results with the patients and the parents on the day, and they find this reassuring because a lot of parents are looking for answers. They always ask me, can I have a colonoscopy? Can I have this? Can I have that? And I say to them, let's just look at the basic and see whether he's doing things properly first. I told them to continue with the same medication because that seems to be working and I don't want to disrupt that. And I said for them to focus on the toilet routine and to do these exercises every day for about 1 minute. Told Mario not to withhold because he has a tendency to do that when he's playing a game or when he's at school. And many times I have to provide a letter to the school to explain that this is very important and they should be doing more to deal with it.
Thank you, Eleni. Very interesting case. So you basically said that you treated this patient with biofeedback, right?
Yes.
So this is my question. In Italy, we find some difficulties at training, educating people, nurses, therapists, to learn this kind of programs. So do you have courses or training days for nurses or not for doctors? Because, you know, it's hard for us surgeons to follow and to learn these programs. But, you know, what can you tell us about this?
I mean, I'm hoping that one day I'm going to have a nurse who can take over this because I don't have the time to do biofeedback. I don't have the training and study day that I have every year. I incorporate a biofeedback training. And to be honest, I'm not an expert. I'm not a physiotherapist. I'm not a nurse who spent years doing this, like a lot of my adult nurses that I worked with. But I find that the manometry itself, the screen, is telling the child exactly what they should be doing. And if you just simply go through a bit of pelvic floor with them, I find it very useful. What I was doing was I was teaching them on the day, and they'll have a bowel diary, they'll tell me when they did it, and 6 weeks later, they tell me the outcome. And we found that there was improvement. A lot of them didn't want to repeat the physiology to demonstrate that. Some wanted me to come back to do the physiology to see if they're doing it correctly. But we did find improvement. And it's just, I think it's just making them aware of what they're doing. And if you're going to do manometry, just do it at the time. It's very, very simple. It takes a couple of minutes. I'm sure physiotherapists or some of the nurses might argue this point and say you need much more time with them. But I think the more information you give them, the more as a child they can become overwhelmed. And I just want them to do it. A lot of them are not compliant. So I explain it to them like bum yoga. I say to them, it's like yoga. You go
Mhm.
and you do these exercises and you'll see a difference slowly. But yes, if you come to my training day, I will go into it. I haven't written this up yet, and I haven't done anything formal training because I'm not a physiotherapist or a nurse. But I think if you can have someone, which I'm trying to get myself to train them, it'll be great if they can invest more time into it.
Please, Eleni, I'd like to remind you to consider our group, our team from Bologna for your training and study days. We hope
Absolutely.
that 2021 will be a better year.
Yeah, I hope so as well.
Professoressa Ricci-Petitoni aveva una domanda prima, forse? No, ok, va bene. Ok, thank you Eleni.
Forse, scusami Nil, avevo una
Sì,
domanda ma forse tardi. La mia domanda era se tutti quelli che avevano il retto dissinergico avevano anche, che era la defecazione dissinergica, se avevano anche una dissinergia dal punto di vista vescico-sfinterico. Cioè quante sindromi di Inman stanno in questi
lo
pazienti.
chiedo alla dottoressa. Eleni, Professor Ricci-Petitoni, who is the chief of pediatric surgery in Pavia, wanted to ask you if children with dysynergia, rectal dysynergia, had associated also bladder and urinary dysynergia. What's the relationship between the two systems when we talk about dysynergia?
I believe that, I mean, I haven't looked at these in isolation as yet, but I think that if they are impacted and they're not using the pelvic floor muscles correctly, of course, one's going to impact the other. You know, they have that anatomical relationship in terms of position. So I think biofeedback, I've had some patients who have said to me, it's helped me a bit with the constipation side of dysynergia, but it's also helped the bladder incontinence. So it's amazing how a simple pelvic floor exercise can impact both. But again, I'm not the expert, and I'm not very, you know, I don't spend a lot of time doing this, but what I have found is a simple tool like this has been quite useful.
Thank you, Leni. One last question from Rome. I think the question is related to the case study. Renato, was it your question?
Yes. What do you think about a trial with Botox in type 2 dysynergia?
Yeah, I mean,
Together with biofeedback.
Yeah, I agree. So one of the things I find very useful when I work with these children is that if they have an element of hard stool or pain or withholding, I say to all the surgeons, do Botox, and then we teach them biofeedback, because then they have the confidence that it's not painful anymore. They can relax that sphincter, and it has worked, that combination together. But again, I haven't, you know, these are just based on what I see every day. I haven't done, you know, great research on this, but I find that combination is very good, because that child has lost that confidence to sit on the toilet because it's too painful, it's too hard, it's too much. But once they've had the Botox and they're relaxed, I say straight away to the parents, please start doing biofeedback, start having toilet training. And I don't know how many I've been successful with, but there's been quite a few, which it's common physiology, I find. It makes a lot of sense. I haven't written that up either. You can see how much information we're getting from all these patients and how much more research we can do. But I think it's taking me a very long time to go through everything.
All right, well, that's normal. Thank you, Eleni, again for your participation. If we have some difficult cases, we'll ask for your help, and we hope to see you soon.
Thank you very much for having me. I've enjoyed it. I'm sorry I can't stay. I'm off to theatre in the next couple of hours. So thank you, and hopefully I can come and visit you in Italy as well, because I love Italy very much. So thank you very much.
Ok, thank you again. Bye.
Thank you. Bye bye.
Allora, per tutto l'audience, noi adesso siamo un po' in ritardo, avremmo la pausa pranzo e alle 13:30 dovrebbe intervenire il dottor Tambucci, e magari ritardiamo, se siete tutti d'accordo, di un quarto d'ora, e ci vediamo alle 2 meno un quarto, 2 meno 10. se Renato sei d'accordo.
Sì, per me...
No, più che altro perché adesso devo andare in sala a preparare per il botulino, quindi ho bisogno comunque di 10 minuti di stacco.
Per me anche alle 2, cioè alle 2...
Ok, facciamo alle 2 allora. Alle 2:05 ci vediamo qui, così cominciamo alle 2 precise. Va bene.
Ok.
Grazie.
A
A
dopo.
dopo, grazie a tutti.
Grazie.
Grazie a